Good morning, good afternoon, and welcome. Thank you for joining us in our Prevent, Protect, Provide educational webinar series. We want to thank clinicians from around the world who have taken time out of their busy schedules to join us here today. The Prevent, Protect, Provide series has been developed by Mölnlycke to provide practical evidence-based education for infection prevention specialists around the world, supporting efforts to reduce healthcare-associated infections and improve patient outcomes. My name is Celeste Chandonnet, and I'm the Clinical Director of Marketing for Antiseptics at Mölnlycke. As an experienced nurse and infection preventionist, I understand the complexity of implementing effective infection prevention strategies in real-world clinical environments, and the importance of approaches that are evidence-based, practical to implement, and sustainable. Today's session focuses on an area of growing importance, the role of the nasal microbiome as a reservoir for infection, and how they may influence the way we think about infection prevention in healthcare settings. Today, we're very pleased to be joined by two distinguished speakers, Professor Michael Wilson, Emeritus Professor of Microbiology at the University College in London, and Dr. Nicolas Loebel, Professor and Chief Technology Officer at Ondine Biomedical. We'd also like to start by briefly mentioning the learning objectives for today. One, to describe the microbial ecology of the nasal vestibule and its role as a reservoir for clinically significant pathogens. To explain how nasal carriage of organisms such as Staph aureus can contribute to healthcare-associated infections, including SSIs. To assess limitations of conventional infection prevention measures when endogenous microbial reservoirs are not addressed. And to identify the potential role of nasal decolonization strategies within a comprehensive infection prevention approach. So we'll begin by exploring the science behind the nasal microbiome and its role in infection. I am pleased to welcome Professor Michael Wilson, who will discuss the nasal cavity as a microbial ecosystem and its significance as a reservoir for pathogens. Professor Wilson?
Okay, thank you. Good afternoon, everybody. Okay, so the title of my talk, my part of the talk, is Why Clean the Nose? And a short answer to that is the nose is the main reservoir of Staph aureus, which is a microbe most frequently responsible for surgical site infections, as well as other healthcare-associated infections. But in the next half an hour, I'm going to put a little bit more flesh on that rather skeletal response. So we'll start off with some epidemiological data, a little bit dull, but important, that sets the scene. In the recent information from the USA Centers for Disease Control, as recent as January of this year, show that surgical site infections account for 20% of all healthcare-associated infections. They're associated with a 2 to 11-fold increase in the risk of mortality, and it's one of the most costly types of healthcare-associated infections, with an estimated annual cost of about $3.3 billion. And it extends the hospital length of stay by 9.7 days, and the cost of hospitalization is increased by more than $20,000 per admission. And the United Kingdom, things are just as bad. In a survey carried out over the 5 years, 2017 to 2022, it was shown that 11% of 50,000 patients developed a surgical site infection. The estimated additional length of hospital admission was a day, and the total health service costs of wound management following this was about £3,500 per person. So the microbes responsible for these surgical site infections and other healthcare-associated infections, up to 67% of all SSIs are caused by Staph aureus. And other organisms involved obviously include things like the coagulase negative staphylococci, enterococci, Escherichia coli, Acinetobacter, and then smaller proportions of Corynebacterium, Pseudomonas, Serratia, and various anaerobes. Interestingly, more than 80% of SSIs have been shown to be due to Staph aureus carried by a strain of Staph aureus carried by the patient himself. And 14 to 28% of the isolates are MRSA. Catheter-related bloodstream infections are also very prevalent healthcare-associated infections, and more than 250,000 of these occur per year in the USA. And the attributable mortality rate is 12 to 25%. And Staph aureus is a frequent cause, about 13% in the USA. It's the second most frequent cause. The most frequent cause is coagulase negative staphylococci, about 16%. And it's a result of biofilm formation on the catheter surface. And I'll talk more about catheters later. Biofilms later. So basically, how do we deal with this? How do we deal with this troublesome bacterium? And a good starting point is provided by the advice of a 6th century BC Chinese general and military strategist called Sun Tzu, who wrote a defining book called The Art of War. And I believe it's still consulted nowadays by military strategists. And the central theme of this book was Know Thine Enemy. So the idea is, if we get to know Staph aureus better, we'll be able to exploit its vulnerabilities, we'll be able to assess its strengths and try and curtail those or avoid those. So I'm going to spend some time now talking about Staph aureus. To many people, it's just two words without anybody actually appreciating that this is a living organism, and we need to get down and dirty and start thinking like Staph aureus. So get into the mindset of this organism. This slide shows Staph aureus on the surface of nasal epithelial cells. You can see it's quite small in relation to the size of the epithelial cell. It's the scanning electron micrograph shows it's got a diameter of between about 0.8 and 1.2 micrometers. This is a transmission electron micrograph, which shows that it's got a typical gram-positive cell wall, rather thick cell wall. And notice this stuff here. This is surface-associated material, or capsule. It's shrunk a bit during the processing for the electron microscopy, and we have to think of it as more of a dense coating around the organism. You can see the invaginations of the cell wall here as this organism, this particular cell, is about to undergo binary fission. So what are the main characteristics of Staph aureus? Well, it's a gram-positive coccus. It's a facultative anaerobe. In other words, it can grow either aerobically or anaerobically, which means it's extremely versatile. It can grow over a wide temperature range, although the most rapid growth is between 30 and 37. It grows over a wide pH range from 4 to 10, or with its optimum being about 6.5. So again, it shows the versatility of the organism. It can colonize a wide range of environments, or at least it can survive in a wide range of environments. It can grow at low water concentrations. It can tolerate high salt and sugar concentrations, and it can withstand desiccation. It secretes a wide range of extracellular enzymes, and these are important because they can degrade macromolecules to low molecular mass nutrients. So, for example, DNA, proteins, and lipids can all be degraded by this organism to provide sugars and fatty acids and nucleic acids, which can be used as nutrients. It also produces a wide range of virulence factors, and these have a number of functions. First of all, it will protect against host defense systems. And it can damage host structures, and it can release nutrients from host cells. Many strains of Staph aureus, as we know, are resistant to antibiotics, and so we have the notorious MRSA. Another important attribute of Staph aureus is that it can form biofilms. And a biofilm is an accumulation of large numbers of organisms on the surface, and the organisms are embedded in an extracellular matrix. Now, this electron micrograph, again, because of the desiccation processes during preparation for electron microscopy, have shrunk quite a bit, this purple stuff. But we have to think of Staph aureus in a biofilm as embedded in quite a thick extracellular matrix. The cells in a biofilm grow extremely slowly, and we can have persister forms of the organism, which means that they're quite resistant to antibiotics and adverse environmental conditions. And the extracellular matrix itself will prevent the ingress of lots of harmful substances like antibiotics and host defense systems. It can repel neutrophils and macrophages. So it's very, very difficult. Once this biofilm forms, it's very difficult to get rid of it and to kill the cells inside the biofilm. This slide shows Staph aureus growing on a Petri dish. It's a pure culture of Staph aureus, and it's been put in an incubator which has supplied it with the exact environmental conditions it needs to grow in. It's growing on a nutrient agar plate which contains blood and other nutrients, so all its nutrients are supplied. But of course, in nature, Staph aureus will never grow in a pure culture, and it will very, very rarely be supplied with all the nutrients and all the environmental conditions it requires. So it's not sufficient just to look at Staph aureus in isolation. We have to consider two further aspects of its life. First of all, the environment in which it finds itself, and secondly, the nature of the microbial community of which it's part of. And this brings us to a very interesting controversy, or rather historical controversy. Louis Pasteur, as you know, is the father of the germ theory of disease, and his arch enemy was Professor Antoine Béchamp. And for dozens of years, they debated back and forward about which was the most important. Was the germ, the bacterium, the most important, as Pasteur postulated, or as Béchamp postulated? No, it's the environment, it's the terrain, it's the environment of the organism that's the most important. And Béchamp regarded sort of microbes as a kind of sort of artifacts of the disease process. They arose as a result of the disease, which was due to an imbalance in the environment within the patient. So two very, very contrasting views. It's interesting, if you look at the quote at the top, it is said that Louis Pasteur on his deathbed said, "The germ is nothing, it's the environment that's everything." Now, there's very, very little evidence that he actually said that. And I think this sort of this slander is encouraged by sort of, anti-vaxxers, God knows, these sort of fringe people. So, I certainly don't believe that he ever said that. But Béchamp had a very important point, that the environment does dictate or affect or control the actual sort of pathogenicity or virulence of an organism. And so the environment has to be taken into account. And to give you one simple example, I've already said that Staph aureus can grow aerobically or can grow under anaerobic conditions. Now, when it grows aerobically, it produces carbon dioxide from sugars. And this carbon dioxide can alter the pH of the environment. It's acidic. It can also encourage the growth of organisms that prefer a high concentration of carbon dioxide, like Neisseria species or Haemophilus species. On the other hand, when it grows anaerobically, it ferments sugars to produce lactic acid. Now, lactic acid can be used as a nutrient by other microbes in the vicinity, but more importantly, it will certainly lower the pH, and that can adversely affect or beneficially affect any other organisms in the environment. So it's important to realize that, the environment is also an important aspect to study with regard to Staph aureus. Now, this organism can survive in the external environment. We've shown that it can survive over a wide range of pHs and temperatures and low water content, but its preferred habitat is the body of humans and other mammals. And the principal site colonized by Staph aureus in a human is the nasal vestibule. But other sites include the nasal cavity, the nasal pharynx, the axillae, and the perineum. So let's take a closer look at the environment of the nasal vestibule. This is immediately the external, the nostril, the external nares, opens up into the nasal vestibule, and it's lined with a keratinized, stratified squamous epithelium. This epithelium is similar to skin, so it's got hairs, the short hairs called vibrissae, sebaceous glands, and apocrine and eccrine glands. But after about 2 centimeters, it becomes a non-keratinized stratified squamous epithelium, and then eventually it becomes a more normal pseudo-stratified ciliated columnar epithelium with goblet cells, and this is more normal throughout the rest of the respiratory tract. And it's covered in a layer of nasal fluid approximately 10 micrometers thick. So this is a cross-section through a keratinized squamous epithelium. We can see the keratinized cells, the corneocytes on the surface. So that's it immediately as we go into the nostril. Further back, this non-keratinized squamous epithelium. And the whole of the nasal vestibule is covered in a layer of nasal fluid approximately 10 micrometers thick. So which microbes can inhabit this region? In order to colonize the nasal vestibule, any microbe must be able to tolerate the environment that's offered by the region. It must be able to adhere to some component of the region or to another resident microbe. It must be able to obtain all the nutrients it requires. It must be able to overcome antimicrobial defenses that operate in the region. And it has to overcome any antagonistic forces generated by other resident microbes. So in the nasal vestibule, the oxygen concentration is about 21%. So it's an aerobic environment, low concentration of carbon dioxide. And the pH is 5.5, so similar to that of skin. So it's very acidic immediately inside the nostril, but the pH increases with distance from the nostril. And the main source of host-derived nutrients is nasal fluid, of which about 1 liter is produced each day. So the main sources of nutrients in the nasal vestibule are nasal fluid, secretions from airway epithelial cells, secretions from the submucosal glands, the transudate from nasal blood vessels, tears from the nasal lacrimal ducts, and the end products of microbial metabolism. So put some figures on this. You can see the protein content is pretty high. There are a lot of mucins, a lot of albumin, quite a considerable amount of DNA. There's uric acid. There are macromolecules like hyaluronic acid, chondroitin sulfate, and of course, high concentrations of immunoglobulins. There's also glucose, lipids, urea, and metal ions. So quite a cozy environment for microbes trying to inhabit there, a wide range of nutrients, but the vestibule also has a wide range of host defense systems, both innate and acquired, which of course will be limiting colonization of the microbes. So some of the effector molecules present in nasal fluid are the following. Lysozyme, which is an enzyme which can destroy many gram-positive organisms. Lactoferrin, which can complex iron and stop. Iron is obviously a very essential sort of nutrient for microbes. Lactoferrin can complex the iron and remove it from solution, so preventing access by microbes. But it's also directly antimicrobial. There are also a wide range of antimicrobial peptides, including human beta defensin 1 and 2, human neutrophil peptide, LL37, elafin, staphyrin, lots of things, bacterial permeability increasing protein, and of course, IgA, IgG, and IgM. So a wide range of effector molecules there. So where do microbes actually live in this nasal vestibule? As I've pointed out, the nasal vestibule differs from other respiratory tract sites because the anterior portion has got a skin-like epithelium rather than a mucosal epithelium. Therefore, this increases the variety of sites available for microbial colonization. So we have hair follicles, keratinized epithelial cells, non-keratinized epithelial cells, the short hairs, the vibrissae. We have extracellular matrix molecules, nasal fluid, and other members of the nasal microbiota. And in fact, all of these sites are colonized by some members of the resident microbiota. So when it comes to exactly what bugs we find there, well, you get a wide variety of bacteria, fungi, and viruses. The microbiota is very complex and several hundred different species have been detected in the population. The most frequently detected species belong to the genera Corynebacterium, Staphylococcus, and Cutibacterium. This was formerly known as Propionibacterium. Now, the bacteriologists among you will immediately realize that, well, this is a bit odd. Cutibacteria, or Propionibacteria, are obligate anaerobes. But I've just told you that the nasal vestibule is a very aerobic site. It's got a concentration of oxygen of about 20%. So how on earth can these strict anaerobes survive in the nasal vestibule. And this is because of community interactions. Aerobically metabolizing organisms like Staph aureus and Corynebacteria and Neisseria, Haemophilus, etc., will consume oxygen and will generate microhabitats in their vicinity, which would be anaerobic and can enable survival of anaerobic organisms. So here's some hard data. This is a study. It's a study of 210 healthy adults. 100 of the nasal microbiota vestibule of 210 healthy adults. 151 species were detected, and you can see that the dominant organism is Cutibacterium acnes, and then we have some Corynebacteria, Staphylococci, and Staph aureus. Notice 30.54% others. So we have a long tail here. We have small numbers of a large variety of organisms. So the microbiota of any body site is extremely complex. And until about probably 10 years ago, it was a bit of a nightmare. All of these metagenomic studies, which showed that, the enormous variety of microbes at any site on the human body, and they're a bit despairing because, well, what do we do with all this information? But then it was discovered that, basically in many sites on the body, there are distinctive microbial communities present, and these are called community state types. And this applies to many body sites. And so a particular individual will harbor one of these community state types. And in the nasal vestibule, a total of 9 CSTs have been identified. And these are listed here. This is the result of a study of 1,608 adults and 149 individuals over a long period of time. Community state type is dominated by, number 1 is dominated by Staph aureus, type 2 by Enterobacterales, type 3 by Staph epidermidis, type 4 Cutibacterium, type 5 Corynebacterium, 6 Moraxella species, and 7 an organism which is really getting a lot of interest in the nasal vestibule, Dolossigranulum pigrum, and a couple of other species. Type 8 Haemophilus species and type 9 gram-positive anaerobic bacteria. So these are the 9 community state types, and an individual will have one of these community state types. The most prevalent is type 5, dominated by Corynebacterium species, followed by type 9, gram-positive anaerobes, type 4, the Cutibacterium, and type 1, Staph aureus. So this shows the frequency of detection of these in the general population. Now, these communities, are stabilized by an interplay between beneficial and antagonistic interactions among the constituent organisms. And to give you some examples of beneficial interactions, this column shows the interacting microbes, and this is the nature of the interaction. So a very important beneficial interaction in any microbiota, but it also occurs in the nasal vestibule, is cross-feeding. So Staph aureus will degrade DNA, proteins, lipids, and hyaluronate, and will release low molecular weight compounds, which other organisms, as well as Staph aureus, can use as nutrients. That's a very important mechanism. Staph aureus can kill lots of host defense cells and degrade antibodies, and this will enable survival of other respiratory microbes. Now, this Dolossigranulum species produces lactic acid, which lowers the pH and encourages the growth of Corynebacterium species. Strep pyogenes and Moraxella catarrhalis coaggregate and increase the adhesion of both species to epithelial cells. Cutibacterium species excrete coproporphyrin 2, which induces biofilm formation and adhesion in Staph aureus. Then we have Moraxella catarrhalis, which produces outer membrane vesicles that bind to C3 and impede complement killing of H influenzae. Corynebacterium accolens enhances the growth of Dolossigranulum pigrum, and as does Corynebacterium pseudodiphtherium. Another example of cross-feeding is Streptococcus species. Many Streptococcus species can hydrolyze chondroitin and releasing sugars, which can be used as nutrients by many respiratory microbes. So within any community, this slide shows a simplified, has to be extremely simplified diagram of the kind of nutritional interactions that occur in a community in the nasal vestibule. I've simplified it tremendously, otherwise it'd be just far too complex to appreciate. But for example, Dolossigranulum pigrum produces lactate, and lactate is used by Cutibacterium. Cutibacterium produces propionate and acetate, which are used by many nasal microbes. Staphylococcus can degrade DNA and produce purines and pyrimidines, which are used by many nasal microbes. Staphylococcus produces CO2 when it's metabolizing aerobically, which can enhance the growth of Cutibacterium, Haemophilus species, Neisseria species. Dolossigranulum pigrum will also hydrolyze proteins and produce amino acids, which are used by most nasal microbes. Staph aureus, or Staphylococcus species in general, will degrade lipids to fatty acids and glycerol, which can be used by many nasal microbes. So that's just a snapshot, a partial snapshot of the complex nutritional and other interactions that occur within any community in the nasal vestibule. But what about the downside of this? There are many antagonistic interactions which occur amongst respiratory microbes. And I'll give you some examples, and I won't list them, I won't describe them all. I'll describe the ones that are particularly of interest to Staph aureus. Now, Staphylococcus lugdunensis produces an antibiotic which can kill Staph aureus and strep pneumoniae. So this is very, very useful, not just of academic interest. I mean, it shows that it suggests the possibility of probiotics for inhibiting Staph aureus in the nasal vestibule. And there is some research going on to try and use Staph lugdunensis for this in this function. Corynebacterium jcaeum inhibits Staph aureus. So again, here's a possible, and Corynebacterium acalens inhibits Staph aureus. So these are other possible probiotic organisms that could be used therapeutically or preventatively. There's a lot of interest in Dolossigranulum pigrum, which inhibits Staph aureus. And there is a lot of research going on to see if this organism could be used as a probiotic. So there are some examples of organisms which could possibly be used to control colonization by Staph aureus. Now, as well as harboring Staph aureus, the vestibule also contains is an important habitat for a variety of other pathogens, including Strep pyogenes, Haemophilus influenzae, Strep pneumoniae, and Moraxella catarrhalis. Carriage of Staph aureus in adults is well known. Persistent carriers, about 30%, but in different studies it ranged from 20 to 80%. Intermittent carriers around about 30%, with a range of 16 to 70%. And the main site of colonization is the non-keratinized, is the junction between the keratinized and the non-keratinized squamous epithelium. So we know exactly where Staph aureus lives in the nasal vestibule. Risk factors for carriage are being a healthcare worker, being under 30 or over 60, being male, having skin diseases, having other health conditions such as diabetes or HIV, being obese, using hormonal contraception, recent antibiotic use, intravenous drug use, a history of hospitalization or medical intervention, being another household member being colonized, and working with animals and livestock. Staph aureus, of course, we said its main habitat is the nasal vestibule, but it can be transferred from the nasal vestibule to other body sites via the fingers of the patient, by aerosols, either directly or indirectly, and also via fomites and, of course, by medical personnel. So why is Staph aureus so well adapted to life in the nasal vestibule? Well, it can grow in the presence or absence of oxygen. So it means, it's very, very versatile in the sense of atmospheric requirements. It can grow at the low pH, which is found in the nasal vestibule, Remember, it's as low as it could be as low as 5.5. It's got a wide variety of adhesins, and so it can adhere to many substrates present in the nasal vestibule. Now, an adhesin, the way in which microbes stick to substances, either surfaces or cells or other microbes, is via surface molecules, which we call adhesins. And an adhesin will bind more, to a complementary receptor on a host cell or to a macromolecule or to another microbe. It's a morphological lock and key type interaction. And we'll come back to this later. Staph aureus produces a wide variety of bacteriocins and so can inhibit other microbes. It can utilize as nutrients a whole variety of macromolecules which are present in the nasal vestibule, and it produces a wide range of toxins that can activate host defense mechanisms as well as liberating nutrients from host cells. Now let's look at some adhesins. There's a wide range of adhesins here. We've got fibronectin binding protein A and B, which can bind to fibronectin, fibrinogen, elastin. We've got collagen adhesin, which can bind to collagen. We've got bone silo protein binding protein, which can bind to bone silo protein. We've got a 60 kilodalton protein, which can bind to human mucin, as well as other proteins which can bind to nasal mucin. Now, these adhesins are not just of academic interest. It suggests a way of preventing colonization by Staph aureus. For example, if we could identify, we have the actual adhesin site, which is responsible for binding to these receptors, we can produce low molecular mass mimetics, which could be applied to the nasal cavity and block these receptor sites, and so hence prevent Staph aureus binding to the nasal vestibule. And this means, of course, that it can't colonize there. And so we've got a good way of preventing colonization. And there's a lot of research going into this at the moment. Host macromolecules which can be utilized by Staph aureus include proteins, lipids, DNA, and hyaluronate. They can all be degraded by these by extracellular enzymes to end products which can be utilized by Staph aureus and, of course, by other nasal microbes. Staph aureus is very good at evading host defenses. The alpha toxin produced can disrupt epithelial cell junctions and so enable invasion of Staph aureus into the epithelium. Leukocidins, a wide range of leukocidins, which will kill white blood cells, neutrophils and macrophages, as also do phenol-soluble modulins. These can kill white blood cells. The capsule of Staph aureus will inhibit phagocytosis. Staph aureus, the surface of Staph aureus is also covered in protein A, and this will inhibit phagocytosis. Proteases will hydrolyze antibodies, so reducing their effectiveness. We have fatty acid metabolizing enzyme, which neutralizes the antibacterial effect of fatty acids. Chemotaxis inhibitory protein, which will inhibit neutrophil recruitment, and staphylococcal complement inhibitor, which inhibits complement activation. So a wide range of virulence factors which can help Staph aureus evade the host defense systems. In its competition with other nasal microbes, Staph aureus produces a range of antimicrobial compounds which can inhibit the growth of a wide range of species, micrococci, streptococci, coagulase negative staphylococci, gram-positive species such as Listeria monocytogenes. Interestingly, some of these bacteriocins are strain specific, and they're produced by one strain which will inhibit other strains of Staph aureus. So we have a wide range of antimicrobial compounds which will help Staph aureus to combat other organisms which are trying to colonize the nasal vestibule. So to end up, these are the take-home messages from this talk. Staph aureus is the main cause of surgical site infections and is important in other healthcare associated infections. The nasal vestibule is its main habitat. It's well adapted to colonizing this habitat, and large proportions of the population carry the organism. And many clinical guidelines recommend nasal decolonization for patients undergoing surgery. So, for example, the Centers for Disease Control and Prevention in the USA, the National Institute for Health and Care Excellence in the UK, and the WHO all recommend nasal decolonization. So that's about it. Further reading, 2 books you might be interested in. One is The Human Microbiota in Health and Disease, which obviously describes, is all about the human microbiota, and a book, Close Encounters of the Microbial Kind. And I'm very pleased with that title. I think it's a really nice title. But to my dismay, I was in Waterstones the other day. My book wasn't displayed, but there was another book called Close Encounters of the Fungal Kind, which is widely displayed, so very annoying. This is a layman's guide to all the different infections that commonly affect human beings. Okay, that's it. Thank you.
Well, thank you, Professor Wilson, for that clear and insightful overview. Just a reminder, you can put questions in the chat if you want, and we will have time for some questions after our next speaker. We will now hold scientific foundation by looking at how these insights translate into infection prevention strategies. So I'm pleased to now welcome Dr. Nicolas Loebel, who will explore approaches to addressing endogenous infection risk, including targeted nasal decolonization in emerging technologies. Dr. Loebel, to you.
Thank you. I'm just going to tee up my presentation here. And thank you to the organizers for the opportunity to speak at Mölnlycke. To the audience all over the world, thank you for your time. And indeed for the opportunity to speak with a world-renowned microbiologist, Mike Wilson. Very appreciated. I'm going to be addressing the endogenous infection risk that is associated with the anatomy. Obviously, Mike has given us a detailed view of what's inside the nose in particular. We see a Trojan horse image there because that's where the microbes are masquerading as non-pathogens, but in fact can cause extreme difficulties downstream in the surgical process. So ignoring the nose undermines everything else. We can appropriately manage the patient. We can appropriately manage normothermia in surgery, pre-surgical prophylaxis with antibiotics, etc. We can decolonize the skin. Hibiclens, Hibiwash, Hibiscrub are great options to do that. But unfortunately, the nose is a warm, wet, sugar-filled environment that's relatively undisturbed. And you can appreciate from Mike's discussion just how many colonizers exist of various forms, all of which talk to each other, talk to the host, host talk back to the microbes. And it's very difficult to eradicate that Nereis population. And so the patient can breathe that population of bugs onto themselves, onto the injuries that they may have come into surgery with, those incisions that are made by the surgeon, and certainly onto the healthcare workers and onto the environment itself. So managing the nose is critical in order not to undermine everything else. But strangely, nasal decolonization, nasal disinfection often takes a back seat to more conventional forms of infection control. And this happens worldwide. I'm the Chief Technology Officer and President of a company called Ondine Biomedical, where we spend a lot of our time educating practitioners, infection control specialists, nursing staff, even indeed the C-suite of hospitals, about just how important the nose is and just why nasal decolonization is such a critically important portion of infection control. We are advantaged by much information, in particular, as you see on this slide, information coming from studies conducted by HCA Healthcare, a very important organization, a company that we're working with closely within the United States, roughly 200 hospitals, 2,000 sites of care, 5% of all US healthcare. They've done some really remarkable work in decolonizing the nose and looking at what the outcomes are of those decolonization events. And these are in massive studies. You can see the number of patients there on the left side of the screen. Epidemiologically sized 500,000, 750,000 patients studies in multiple years, many hundreds of hospitals. But the take-home message here is that nasal decolonization is associated with large reductions in infection rate. Okay, the type of agent is important. We'll cover that in a minute. But the key thing is almost half of the infections that are suffered in tertiary care systems can be offset by nasal decolonization. Again, large studies involving preoperative decolonization, ICU decolonization, universal decolonization, meaning every patient, irrespective of PCR detection of whether you have MRSA or not. So let's look at the traditional options to sanitize the nose. There are topical antiseptics, which are applied either the day of or before surgeries, often after post-acute, after surgeries. And then there's the topical antibiotic mupirocin, which is considered to be the most conventional market leader. Mupirocin is an antibiotic, pseudomonic acid, that was developed years and years ago. It is used in every single critical care and pre-surgical theater that we're aware of. It is a multiple time a day, 5-day precursor to surgery regimen. It is a bacteriostatic compound, not a cidal compound, so it must be used for quite some time, up to a week before surgery, in order to ensure suppression of Staphylococcus. It is also a narrow spectrum anti-staphylococcal, which means that you leave behind a lot of the bugs that you want to kill in order to be effective against surgical site infections. We'll cover that in the next few slides. Topical antiseptics can be faster. They can be contact killers, but we see that there are numerous issues associated with their use, and we will cover those too. In particular, povidone iodine, leaving behind free iodine, and octenadine, which is an analog of chlorhexidine. Limitations are that, as I said, mupirocin fails to protect against anything that is not directly staphylococcal. PI can handle those broad spectrums, and so can octenadine, but they start to fail elsewhere. Mupirocin is a 5-dose, twice a day prophylaxis. Povidone iodine must be applied more than once and must be kept wet. The povidone film that forms on top of the iodine maintains a wet milieu against the nasal microbiota and against the nasal epithelium. And so removing that or allowing it to dry reduces effectiveness. Octenadine must be applied multiple times, although that is only approved as a wound care wash, but it is used off-label in the nose. Mupirocin is associated with up to 80% resistance formation. That's a really key observation by multiple studies. Using mupirocin is not different to using antibiotics at low dose for multiple days. Unless you kill the entire population, and mupirocin has difficulty doing so, you end up with resistant clones, which end up ultimately becoming the predominant clone in the nose. And so the hospital antibiogram reflects that. It's not just at the patient level. The hospital antibiogram reflects over time the fact that the clones are mupirocin resistant. And that, of course, produces quite a serious gap in the infection control paradigm. Mupirocin resistance is conferred by a gene called MUP-A, and that is now mutated. MUP-B genes exist. Those are not detected well by PCR. So screening patients is often a waste of time because A, it's expensive, B, it takes a long time, and C, the clones can be resistant. So you would not know that if it wasn't a MUP-A gene. Similarly, mupirocin and the other agents are difficult to ensure that they get used. In a major study by HCA Healthcare, it was demonstrated that full adherence to a mupirocin protocol in hundreds of thousands of patients was below 40%, which means that when you give the authority to a patient to participate in their own prophylaxis, you're taking a major chance. Unless that patient is specifically motivated by prior knowledge, by practitioners who follow up expensively with the patient, over half the patients will not complete the course of therapy. It's too difficult to rub this ointment into the nose twice a day, do it appropriately, and then generate this antistaphylococcal response. And so the patients come in telling the practitioners that they've done the treatment, but unfortunately, many of them haven't. Some of them have done it partially, some of them haven't done it at all. So workflow in the hospital is impeded by having to sequester these patients and provide for insurance that they have been decolonized. And the same is true with the other agents. If we look at a slide that demonstrates the impact of mupirocin, and we can extrapolate this to other infection control paradigms, you saw in Mike Wilson's talk how many species are involved in this complex microbiota of the nose. Well, they can all contribute to infections. Enterobacter species contribute to infections just as well as Pseudomonas species. Staphylococcus is a big one, but you find that E. coli can produce even greater number of infections. Mupirocin, as I said, narrow spectrum antistaphylococcal. What are clinicians going to do with the balance of the microflora? Providing your patients with mupirocin is dangerous. Over 5 days, you can produce about a 30% eradication of source. That is inadequate to maintain an appropriate infection control regime. And so we bring this slide with the sense that most clinicians assume that because mupirocin is the most widely used agent and one that has been in use for many, many years, it is in fact effective. Be careful, it leaves behind 2/3 of the bugs. So an issue with mupirocin that is often not talked about is the fact that it has a long-standing impact on nasal microflora. When you look at the attributes of a perfect decolonizing agent, you want a short-acting substance. You don't want something that's going to be there for a long period of time, suppressing microbes, because we all know about the influence of the good bugs on the bad. If you destroy too many microbes, if you disrupt that delicate balance, and in some cases that adverse balance that was shown in Mike's talk, you can eliminate host species that are extremely important in the maintenance of normal microflora. And so the presence of this substance mupirocin can in fact disrupt the microbiome, which allows for other organisms to get a foothold. We've seen Candida albicans among others. But in particular, this is a very interesting slide because Beatty showed in 2022 using careful RNA-based methods. RNA is indicative of live bacteria, not dead bacteria. RNA leaves quickly, so you need to use PCR and amplification methods for the RNA component. That even patients that show up at day 0 free of Staph aureus and are then treated with mupirocin can become staph carriers 1 week later. And we start to see the growth of staphylococcal clones. And that's very interesting. It's implying that the disruption of the microbiota is permitting the very pathogen you're looking to avoid back into the microbiota itself. And when you look at how mupirocin works, you'll see that in Staph aureus carriers, the adjustment, the modification of the microbiome is profound, and it can be profound up to 6 months. Now, the Bray-Curtis dissimilarity is something I won't go into in this presentation, but you certainly look at that later. It's a measure of the complexity, the frequency of species, and the diversity of the microbiome. And you can see how it starts with a normal microflora and ends up relatively disrupted for months. And that occurs in both staph carriers and non-staph carriers. So 2 take-homes from the slide. 1, non-carriers treated with mupirocin can become carriers within a week or less. Now, if they have exited the hospital, they can then not be a threat directly, but they can contaminate healthcare workers and the environment and that hospital antibiogram with clones that will generate this effect. It's a very dangerous problem downstream of mupirocin. So I'd like to spend a few minutes on a brand new technique, or perhaps a technique you've used now that we have relatively well understood process in the NHS, for example. Certainly, we are in the regulatory approvals of 37 countries, mainly in Canada. But I'd like to talk to you about what nasal photodisinfection is. It changes what is possible in terms of disinfecting the nose. We've seen this characteristic slide before, and we can honestly say that photodisinfection is capable of achieving all of the objectives of a perfect decolonizing agent. One, it is effective against all types of pathogens. And by that, we don't just mean effective against particular species. We mean all types, bacteria, fungi, and viruses. It is immediately microbicidal. That's both immediate and cidal. So that's a lethal combination. The immediacy permits the workflow to handle patients who are coming in emergent, high acuity patients, the patient coming in from the accident on the freeway, all the way to the 3 a.m. Patient needing a spinal procedure with a tumor on the spine and cannot be decolonized using a static agent. Over many, many years of repeat dose challenges to the technique, no entity, no researcher, and certainly not ourselves, have ever been able to demonstrate the development of antimicrobial resistance. That's a key point. When you kill something as complex as a microbe, with its gene expression interior, with its complex cell membrane, with its expressions of multiple virulence factors and proteins, you can quickly generate antimicrobial resistance. You do so because the compound is there for a long period of time, because the killing effect is static, and because you do not kill all of the microbes. If you can kill all the microbes, if you're only present for seconds to minutes, the genome never has the opportunity to see the killing agent. And so you don't generate this resistance. It's one of the theories behind why the resistance proof aspect of photodisinfection is so key. Of course, since it is so fast, we don't leave it to the patient to deploy. It's deployed by the healthcare practitioner, be that a nurse, infection control professionals inside the pre-surgical environment, the ICU environment, critical care environment. That produces remarkably high compliance rates. Our studies have shown well in excess of 96%. And that's key because we close that hole in your infection control paradigm. And of course, that would not be possible if we had to provide nursing staff with a complex regimen, a regimen that needed adherence to anything that took more than a minute or two out of their workday. It looks like this. There is a particular agent. It's a bacterial stain, which is provided to the patient on a pre-saturated swab. You see that on the left side of the screen. Just place that into the anterior nares, not as high as the turbinates. This is not a COVID assay. This is not an attempt to get up beyond the first third of the anterior nares. And that's where the bugs live. And in particular, there's a reservoir right in that nasal vestibule. And at the tip and around the interior, we swab using a painless, cool, flavorless liquid. It is colored blue. The patient may demonstrate a slight blue ring. The active ingredient in the photosensitizer is methylene blue. It's particularly stabilized. It's in a particular redox environment. It's got a particular set of factors that associate with high kill. It's boosted, but it's something that works extremely well to stain microbes. In fact, part of the reason for its development initially was as a microbial stain. It doesn't stain human skin well, which means that selectivity allows us to kill the bugs and not destroy the human cells. That's a function of its charge. It's electrostatically a cation. It's positively charged. Your human cells are neutrally charged. Most microbes have anionic negative charges on their surfaces, which causes the electrostatic attraction and the selectivity. We then bring in light. This is cool laser light. It's about a watt per channel of each of the two halves of your nose. That light is painless. It doesn't flicker. It doesn't induce any outcome to the patient. It doesn't produce any heat. and it's there for about 2 minutes. You then repeat the therapy for another 2 minutes for a total of 4 minutes. You then throw away both the swabs and the light guides in medical waste. And on the right, you see real slides from real human patients. That's what a MRSA 4+ patient looks like, swabbed from a pre-surgical clinic. And that's what happens after photodisinfection. And you can see the same effect after patients who are associated with fungal infections. By the way, extremely effective against Candida auris, which is a similarly dangerous microbe beginning to be seen in many hospital environments. It's a bacteria yeast clone, which is very difficult to eradicate because it's highly resistant to the azoles, fluconazole, etc. No problem with killing that, as any other microbe, including genetically engineered microorganisms designed for resistance. Photodisinfection is extremely potent. Just a couple of slides further on mechanism of action. So we've talked about the selective uptake of methylene blue due to its cationic charge. You see that charge there on one of the oxychromes that attaches to the bug, and human cells with their zwitterionic net negative cell membranes don't take up this stain. I'll just move through this photophysics component quickly. Photons of light that come in generate free radical oxygen through a photodynamic cascade. Won't go into the details, but effectively a set of photons coming in, free radical oxygen coming out, and those are responsible for killing the bugs. Remember that the methylene blue is directly associated with the surface of the microbes. Michael, this is for you. Is everything going okay on my screen? You can see my screen?
Yep, we can see the screen. Thank you.
Thank you very much. I've got a couple different screens showing different things here. So that's about all we need to know about the photodynamics. Perhaps I'll mention one other thing. Because this is an oxygen-derived reaction, producing both oxygen-derived radicals and free radicals, we do need oxygen in the vicinity of the treatment. That, of course, is assured in the anterior nares. But this technique has been used in burns and wounds. It's been used subgingivally, where oxygen tension can be quite low. It's been used inside ventilator tubes, certainly inside the sinus cavities. Deep inside biofilms, there's often a high rate of metabolism, and you can get a lot of oxygen suppression. So the photophysics of this reaction are quite interesting in that you can kill bacteria with and without oxygen. If you're interested, I would recommend you to one of Mike Wilson's texts or other multiple publications on the photophysics of photodynamic reactions. Fascinating how it can switch between oxygen and oxygen-free substrates. So let's take a look at the immediate effect and also this construct of the microbiota being preserved. A single dose of this technique inactivates 3 logs plus of nasal microorganisms within minutes. And recall, it doesn't have anything to do with what we today consider resistance. Resistance is an antibiotic susceptibility or an antiseptic susceptibility issue. It does not have any meaning within a photodynamic world. This technique couldn't care whether you were disinfecting the bottom of a shoe or a XDR organism or a susceptible organism. They're all the same. They peroxidate easily. The surface oxygen radicals destroy the membranes and quickly kill the microbes. Now, when you look at the range that is possible, you see that this is a remarkable technique that really isn't matched in today's clinical armamentarium. You just don't see something able to disinfect the entire range, phyla, complete orders of microbes, much less species, including viruses. We were heavily used during the COVID pandemic. And that's something that's really interesting because of that breadth. You don't need to worry about whether the antimicrobial has been matched to the target microorganism. And in particular, you can also see that the technique is designed to work over the surgical period. and not beyond it. Once primary wound closure has occurred, you don't need that antimicrobial to be in place. In fact, it's counterproductive because you will inhibit the normal microbiota. And so it's critically important that it's a short-acting compound. And we've done extensive work using sequencing to determine whether the normal microflora is reestablished quickly. In about a week, the patients are back to normal using photodisinfection. So the effect can last up to a week, but in about that week, the Bray-Curtis distances resolve back to the kind of diversity, the kind of microbiota that was present before the technique. That cannot be said for mupirocin. So once we address all of the pathogens in the nose and we look at the very fast response, we get to a question that we're often asked, which is, of the strains that you have tested, have you found anything that is a pathogen you can't kill? Is there something that's going to come out of the woodwork? Will you in fact upregulate us finding that pathogen? And we're very proud to say over a decade, and now probably 1/3 patients treated, we have never found it. For example, certainly highly effective against MSSA and MRSA, and we're highly effective against multi-drug resistance where numerous antibiotic resistances can be seen. And we can show you that we're equally effective against XDR microbes, in which all but 2 of these antibiotics are resistant. What you see when you look at the disinfection is that we drop the microbial titer to roughly the limit of detection. The surgery happens in this area. So you've got yourself a patient who finally can be understood to be fully decolonized in the nose. Yes, there are other endogenous sources of microbes. Do a good job on skin decolonization. Do a good job on ensuring that medical personnel are gowned and appropriately masked around the patient. Do a good job on hair and oral care. But in the nose, we can give you that sense of comfort that you've covered that aspect. And you can see how fast these microbes will grow back if they're not, in fact, decolonized. Again, out to 24 hours, highly effective. And then out to a week, we recover the normal microbiome. I've covered this. It's just showing you that in 25 exposures, that's repeat exposures, there are no increases in resistance. 25 exposures, microbiologists among you will know, takes a long time. That's a 25 reculturing experiment, which takes a very long time. And you can't really express that in weeks or months. That can sometimes take many, many quarters to do. Whereas in 10 exposures, using any methicillin or oxacillin type of derivative, you can quickly form resistance. I mentioned that the antimicrobial effect is extreme, even with genetically engineered microorganisms. Here you can see a patient who is presented with mupirocin-resistant clone, absolutely no response to mupirocin over 24 hours. And we can take that same petri dish, and then we can, just for purposes of demonstration, we can show what happens when we treat that same plate right in the center. You can see how well we can kill these mupirocin-resistant clones. And again, on these genetically engineered clones, which are designed to defeat any modern antibiotic, no concerns with us. In terms of speed, you can see what happens with an antiseptic like PI immediately after and before the treatment. Not much difference in broad spectrum plates, not much different in MSA plates, which are staph specific. By contrast, we're leaving behind very few microbes after that 4 minutes in broad spectrum plates, and essentially no Staph aureus in a selective agar. So that's a kind of graphical image of what you're dealing with immediately afterwards, and why we say that this technique is so important in the emergent and high acuity patient. If you look at octenadine, which we're commonly hearing about in hospitals, the technique using photodisinfection is about 100x or so more potent. This is the outcomes associated with photodisinfection against a range of key pathogens involved in healthcare-acquired infections, and somewhere between 30 and 100 times more effective over the same pathogen. However, notice that the octanidine has to be applied for 18 hours just to get to that level of kill. Photodisinfection is a single 4 minutes, and you're getting to this level of kill. So one treatment, no guesswork, suitable for universal use. I just need to spend a minute on this. It's pointless to go and spend 50, 75, 100 pounds on a PCR assay to screen a patient if it costs you that or less to disinfect them in the first place. Indeed, we know of healthcare workers who have decided that they want to make sure that they don't take community strains into the hospital and hospital strains back to the community and disinfect themselves or disinfect themselves before surgeries to avoid cluster events. The fact is that the universal use of mupirocin is condoned by companies such as HCA because it's the only technique that really works to reduce infections. Subselecting patient groups, those who are PCR positive, or those who have had prior MRSA detections, or those that are sequestered, for example, for a period of 5 days, doesn't work well. The reduced study with many, many hundreds of thousands of patients demonstrated that the only thing that works well is universal use. So that will really only be possible with immediate urgent care compatible effect if you have a broad spectrum agent and if that repeat use doesn't generate the resistance that is seen today with mupirocin. So the fact that you are supporting the antimicrobial stewardship is important. It doesn't destroy the antibiogram in the hospital. I'm going to close with a slide with thanks to Dr. Titus Wong, who is the Director of Infection Control at Vancouver Coastal Health, which is, I think, a 22 hospital healthcare system on the west coast of British Columbia. Titus was one of the early adopters and deployers of this technique in Vancouver General Hospital, now a hospital with one of the lowest infection rates in North America with their continued use of photodisinfection. And he produced this slide for a board review a year or two into their deployment. And I borrowed it with thanks to Titus because it covers the key issues, the take-home messages. 1, do not use an agent which is suppressing anything 6 months from today. You cause microbiome problems. 2, don't leave behind 2/3 of the microorganisms. You're going to get infections, doctor, every other way besides Staphylococcus. 3, try not to produce resistance. It's very difficult in today's age with repeat use, but resistance is becoming the biggest single issue of our time. It will produce more deaths than heart disease and cancer combined by 2050. It will be the single largest cost to the human healthcare system. Resistance generation means we're losing the antibiotic as we know it, and that puts us in a precursor age we don't want to go back to. 4, over 1/3 patients are very comfortable with the fact that it works clinically very well. Reductions in infection rates, reductions in readmission rates, huge reductions in antibiotic use peripheral to the technique. Readmission rates, as I said, are significantly down. Time from emergency room significantly down. There is a large effect here which can be seen across multiple components of the stakeholder spectrum. Nursing staff, CFOs, reimbursers, the patients themselves. Remember, every patient that gets back to a bed because they have to be revision surgery applicable is another patient or two that you can't readmit to that bed under the diagnostic related group. The rapidity is important because nursing staff do not have time to waste. Compliance is critical because you cannot rely on the patient for their own health care. Of course, the fact that it is easy to deploy permits this rapid proliferation across the hospital. And most of all, last but not least, we are to do no harm with any intervention, and so safety is key. Thank you. I will stop there.
Thank you, Dr. Loebel, for outlining those important developments. Thank you both for sharing your expertise with us. I don't know if you have time to stay on. We do have a fair amount of people that are still on and a few questions, or would you rather close out and follow up with questions.
Over to you guys.
If you have time, we can ask a few questions. One of the first questions that came up, it's a trifecta question, but are there any potential issues associated with killing good bacteria in the nose? And will the healthy biome be restored after treatment? And does it matter if the good bacteria are killed as well? I guess you could answer that, Professor Wilson.
Yeah, well, I mean, Nick has already shown that, the normal microbiota is restored very, very rapidly. And it's not surprising, I mean, the nasal vestibule is connected to the nasal cavity where you have a resident microbiota there. And so recolonization will take place very rapidly. So it's not surprising. And there's experimental evidence that this does occur. So no, I don't think there's a problem there at all.
Okay, thank you. Another question, this would be to you, Dr. Loebel, is how many, sorry, the screen just changed. How many UK hospitals currently use photo disinfection, and have you seen any barriers around adoption and how the surgical teams overcome the hurdles?
Thank you. It's about half a dozen hospitals that are currently deploying the system, both in pilot and in full use. What we see is that it's brand new. It's a new technique. Nobody's seen patients with brightly lit red noses before. And so it does produce a certain sense of, wow, this is a high-tech system. We're photonically decolonizing our patients. Will they accept it? What about the workflow? Where do we store the equipment? It's not just placing a bit of goo in the nose. It's also got a laser with a disposable. But those things are so easily trainable and so easily accommodated by the nursing staff that really the deployment of the system is not a problem after the first few days or a week of deployment. What's interesting is to see the response by the clinicians when they look at their infection control data. Those hospitals that actively follow and track their infection rates using whatever techniques, NISQIP or NHSN equivalent that there are struck by the fact that they can so dramatically reduce the infection rates, in many cases, 50% or more. And that's with reference to prior infection control paradigms, not just zero as a standard of care. They're struck by that. And so that then produces a downstream impact. Well, if we're doing it in cardiac, why aren't we doing it in ortho? If we're doing it in ortho, let's go to spine neurovascular. And then, people start to say, right, well, we need to find the money for that. So we're in that early stage of realizing that the costs are dramatically outweighed by the benefits. And people just need time to recognize that in their own hospital system.
Great, thank you. Then there is a request for your presentations and references to some of the quotes, especially the 80% reduction or the 80%, people's
Impact
comments
factors.
keep coming. Yes, people's comments keep coming up, and so the 80% mucin resistance. So if you have references for that, so is that something you guys would be willing to share?
Certainly, we can provide that to you afterwards.
Great. Thank you so much for your time. Again, thank you for sharing your expertise. We have a few more questions, but we will follow up with people directly in lieu of time. But thank you so much. If you have questions following today's sessions, or you would like to discuss how these approaches could be applied to your own settings, please reach out to us. Following the webinar, there is a certificate of attendance to support your continuing professional development requirements. So thank you for your time and participation. We look forward to welcoming you in the next session in our Prevent, Protect, Provide series. Thank you very much.
Thank you. Thank you all.
Thank you.
Appreciate
Thanks.
the opportunity. Bye-bye.